Good morning, everybody. Thank you all for coming this morning. I hope everybody had a chance to do some have initial hellos, good mornings, and had a chance to get coffee. So this morning, we just wanted to start with some opening remarks. I wanted to introduce our director, Karen Kavanaugh, who's going to give opening remarks. Karen is the director of the Office of Health Systems. She started our office. She's the inaugural director of the Office of Health Systems and has been leading the formation and the direction of that office. She's been a real visionary leader for us and has been really instrumental in not only forming the organization of that office, but in leading the development of the staffing and the technical leadership, and also just been a very inspirational and strong leader for us. We've been very lucky to have her. Karen, we'd like to welcome you to give opening remarks and start us off.
Thank you, Jody, and good morning, everyone, and thank you for coming this morning. This is an important workshop, and it's great to see people from a variety of different places and sectors. We all come from different sectors, but what we have in common really is a commitment to improve our understanding of how governance can improve the health sector and how better governance can increase the quality, equity, and affordability of essential health services, especially for poor and marginalized people. I'd like to welcome colleagues from the Global Health Bureau, from the Democracy, Conflict, and Humanitarian Assistance Bureau, our regional bureau colleagues, and partners from WHO, who I understand flew last night and found hotels nearby, and the World Bank, and then a number of USAID implementing partners. On behalf of USAID, I'd like to thank the Health Finance and Governance Project for leading the organization of the workshop. And I'd also like to give a special thanks to Jody, not because she started with such complimentary remarks, but because she and Hila Rasool in Dacha really have been the driving force behind this workshop and championing a holistic and collaborative approach to helping us answer important unresolved questions about health governance. I'd like to frame our discussion today about health governance by sharing a bit about our context. USAID and the rest of the global health community are really at a very unique crossroads. And I guess the way I would characterize it is that the contrast between the narrative for the Millennium Development Goals, where we talked about incremental improvements from a baseline. So if a country had an infant mortality rate of 100 per thousand, they should go down by a certain percent, and it should end up being 75 per thousand. So they should make a little bit of progress against their baseline. But now, really, we've made a totally different we've set a totally different set of goals, and they're, in a sense, defining a floor or, in a way, a universal entitlement to a certain level of welfare and health. And that is looking at, for example, in child survival, talking about reaching a global infant mortality rate of no more than 20 per thousand by 2035. Similarly, our goal for mothers is that no country exceeds 70 maternal deaths for every 100,000 live births by 2030. So that's saying, I don't care if your starting point is 500, you've got to get down to 70, and the global community is there to help you. Likewise, in our battle against the AIDS pandemic, we're now talking about ending the pandemic, not sort of incremental improvements in the situation. So those of us who are in USAID and working in the global health area, we all know about acting on the call. But some of our colleagues in governance may not be familiar with that event or what it entailed. So I want to point that out to you because we created a book which goes country by country for all the priority countries for child survival and maternal survival, and talks about the issues that those countries are facing that we need to help them address. And in many of these, you'll find, if you look at it, that the issues are governance. So in this roadmap that was created for acting on the call, the global health community is identifying what we need to do in terms of interventions. We know which interventions work to save lives. We know which commodities we have to buy. We know the financing requirements, and we know the human resources that are needed. We can even define the information that we need to track progress. So in this context, what's the role of governance in health, and why do we need to pay attention to it? Well, in USAID's Health System Strengthening Results Framework, which we created for the Global Health Initiative a couple of years ago, we envision governance, and I hate to even define it here because I know there are governance experts with far more knowledge than I, but I'll just throw it out here because it's the one that we've come up with in our results framework. But we envision governance as robust oversight, regulation, and accountability for health activities and results in the public and private sectors, and incentives that reward good performance and sanction poor performance. So our goal in governance is to improve health systems capacity and effectiveness to support improved delivery of quality, equitable health services. When we talk about all of these critical elements of the roadmaps for child survival and maternal survival, the interventions, the commodities, the human resources, the financing, the information, really we recognize that governance affects all of these key elements. So we know the interventions, but governance influences who gets those interventions and whether they're delivered with the quality needed to improve health. We know the commodities that are needed, but governance influences who buys these commodities, the rules they use, the processes they use, and whether or not they protect against counterfeits. We know how much money is needed, but governance affects how much of that money goes to health, and also within health, how much of the overall envelope goes to essential services for the poor and marginalized, and how far the money goes. We know how many human resources we need, but governance sets the standards for human resource training. It decides who hires and fires and on what basis. It determines whether the public workforce in health is made up of career civil servants or party loyalists. We can determine the information needed to track progress, but governance drives whether this information is collected, analyzed, and used effectively. So that at the sort of conceptual level is how we see governance affecting our work. But I'd like to mention a few examples of where governance actually we can see that it impacts our ability to deliver on the goals in EPCMD priority countries. So if we take Senegal, it's one of our priority countries, and in many ways it has many things going for it. It's a country with a lot of positive features, but it's also a country with essentially a 3-year gap in its routine health information system because workers in the public sector simply refused to fill in reports as a way of protesting working their terms of employment. Nigeria is another priority country for the goals of child and maternal survival. And it's a country with relatively high per capita income among USAID's priority countries. But it's a country that still has not managed to vaccinate its children, something that doesn't require a lot of money, a lot of skills, or unique capabilities. And India is another priority country where we find that the same health workers who work in the private and public sector work according to totally different standards, deliver totally different standards of care in one context and in the other. So I think we have 2 remaining challenges. We can characterize good health governance. That might be somewhat debatable, but generally we know what good governance looks like. We can identify when it doesn't work well. That's fairly obvious. And we can also identify a range of interventions that might improve it, such as leadership training for public sector leaders, improved systems for procuring and tracking health commodities, and enhanced civil society engagement in priority setting, among others. So my hope is that today's discussion will help us move further in solving 2 big remaining challenges. First, we need to increase our understanding about which interventions are the most cost-effective ways to improve health governance in various contexts. Second, we need to improve our ability to measure and document the magnitude of the impact of these interventions on health system performance and on saving the lives of mothers, children, and people affected by HIV and AIDS. We want to use this day as an opportunity to identify evidence gaps and priority research questions and to develop actionable ideas to link these priority questions with ongoing existing opportunities to strengthen our evidence base. We look forward to using this workshop as a starting point for future collaboration and results. And we look forward to learning more about how better health governance can contribute to a world where women and children have the same chances for healthy lives, no matter where they live. Thank you.
Thank you. Thank you very much, Karen, for really helping us set the stage. I think Karen's remarks really are, first of all, very inspirational, very on target for what we want to do, and really speak to many of the challenges that we face as a public health community, and in particular on this topic on health governance. So I just wanted to spend very quickly 5 minutes to maybe help sort of contextualize a little bit and sort of situate us for the day before I turn it back over to Jawara, who can, probably do this a little better than I can as a facilitator. But really, what we want to focus on today is really, as Karen is saying, how do we look at health governance as sort of a subset of our public health and health systems work, and really work on the evidence needs there. I don't think it's, I'm sort of speaking out of turn when I say that, we have sort of very disparate ideas, I think, about, it's a pretty broad umbrella when we talk about governance, but it's also, I think, something that is really commonly understood as a tremendous need. I think when we all go out to, to the field, or when we're all, discussing it, governance comes to the top as being a tremendous need. So I think when we are all sort of sitting here together, nobody's going to disagree that this is a priority need. But I think what we really want to do today, or the thinking behind this workshop today, is that what can we sort of come to agreement on around some key priority questions, and then what are some of our, how can we sort of coalesce around some of these key priorities as sort of next steps? How do we sort of do sort of some of our strategic, but maybe be a little bit opportunistic about how do we move forward with our evidence agenda? We know that there are challenges in terms of funding, in terms of bandwidth, but how do we move forward in bridging that gap between our health systems interventions and finding out, like Karen is saying, what are the most cost-effective, what are the biggest return on investment, and how do we demonstrate what are the best investments in health governance? Because we all agree this is a need, but there's so much need, and we need to build that evidence base. So I just have 3 quick slides. I want to show this one first because I think when you join the Health System Strengthening Club, it's a law that when you have an event, you have to show the 6 building blocks. No, but I wanted to show this one because, I like the way this one shows the intersection between all 6. And I think governance really is cross-cutting. Joe Namoli, when he speaks later this morning, he's going to really talk about some of the other aspects of the work that's going on in health systems research and really highlight for you how governance really is integrated across all the other work, and that's important to point out. So I really just wanted to show this because I like the way this diagram shows the intersection. So I think this can really sort of set the stage for what I think is a good starting point to maybe help focus the discussion. So I know we can run off in 100 directions about what is governance, what is our sort of priority areas of work around governance. But within our global health work, we have sort of focused on some key objectives. This is not exhaustive work in health governance, but we have honed in on this overall objective, which is to improve health systems capacity and effectiveness in governance to support improved service delivery or improved delivery of high quality and equitable health service. And under that, we have these 4 objectives. This is what we've been sort of working with as a starting point. This is not, again, meant to be comprehensive, but I think it's a good starting point. Developing sustainable country capacity and transparent and accountable policy, planning and management to advance EPC, MD, and AFG goals. And building capacity of civil society and private sector for stronger voice and better advocacy to increase government transparency and accountability. I see people writing, so I kind of feel like maybe I should have done this as a handout. That's my apologies. The third one is improved government effectiveness and responsiveness, including stewardship and regulatory capacity to support improved service delivery. And the fourth one is to develop a new generation of health systems leaders at country, regional, and community levels. I also know we could probably spend a week tweaking this, so wordsmith at your leisure, but I think this is a really good starting point for us today. And then just really quickly, you know, Joe Namoli and I were sort of working with these. One way to also sort of think about these when we're talking about how do you sort of think about these in terms of research and evidence gaps that we could, you know, how we could address them. You know, this might be another way to sort of think about, again, not exhaustively, but a few ways that we could sort of turn them around to think about them in terms of research questions. You know, what are the most effective interventions? What are the most cost-effective, high-impact interventions for these things? What are the role of stewardship and regulation? Or, you know, again, you see the way we were sort of thinking about these as a sort of a first cut. You see the language around cost-effectiveness, you know, cost-effectiveness, effective interventions, and things like that. So this is kind of the way we were doing some initial thinking about this, and I think this is kind of the starting point for how we'd like you all to help us think through these kinds of questions. But this is just some initial thinking, and I think that was kind of how we were hoping, you know, we'd like to get, you know, started. Of course, you feel free to shoot these down, but, you know, this is just sort of our initial thinking about how to situate the discussion. Very, very rough cut. And just to sort of coalesce that then, these are today's objectives as outlined on your agenda. And again, we very much look forward to hearing from you all. And as Karen stated, this is really what we see as the start of a much longer discussion with our USAID and global colleagues on how we can move this agenda forward. So thank you very much.
Good morning again to everyone. Good morning. Okay, it's good to know that you're out there. My name is Jawara Lumumba, and I'm going the wrong direction, but I'm going to go back. So, my job as the facilitator is to get you through this program in a productive way and on time. I'm joined by 2 of my colleagues, Denise Rouse, who's over in the corner, and Kamiko, who's also over in the corner. Kamiko is going to be dutifully taking notes so that we'll have a record of this wonderful event. And Denise is going to help me keep you on time, on course, and have a productive day. Now, you're going to be listening for quite a bit this morning, so I want to make sure you've got the energy to take that task on. And so in 90 seconds, I'm going to ask you to think about your life over the last 6 months. And if you were writing your autobiography, what would you give as a title to that chapter in your autobiography? So you've got 90 seconds to script that. And then, to get that energy flowing, I'm going to ask you to rise and move around, find people that you don't know well, and say, this is the title of this chapter in my autobiography, and briefly why, and then they'll tell you. And so, in a span of 10 minutes or so, I want you to try to touch base with at least 3 to 4 people. This is similar to speed dating, if any of you have ever done that, but we term it speed connecting. So you've got about 90 seconds to get that title, and then I'm going to say rise and mill around and move around. So the time is running.
90 seconds has started?
It has. And I'm often asked, does this have to focus only on your work life? This is your entire life, so you choose what you want to share or that you can share publicly.
Anne's title was lame, I detailed it.
You still have 60 left. So you're down to about 30 seconds. I think most of the pins have stopped. So in another 10 seconds, I want you to stand, move around, have some one-on-one conversations, exchanging these titles and the reason why, and try to touch base with at least 3 people that you don't know already. So we'll begin to do some connecting here.
Does it work if I do it with you?
Of course. What have you got here?
Yeah, I've seen you, I think, a few years ago. I was working with Mac, but I've seen you in some of those, you know, working on human resources for health, which is another problem. You're still a kid, right? Yeah, that's the reason why.
You have 2 more minutes. He's lost.
I don't feel like I know you.
Take 1 more minute. 1 more minute. Let me have you take your seats. Your time is up. Take your seats. Your time is up. I'm sorry. Your time is up. Come back home. Take your seats, please. Well, we definitely have the energy that I had hoped for. So, in both my life as a facilitator and my earlier life as a lawyer, I have active curiosity. So hopefully, in a matter of 1 minute, I can get 2 to 3 people to volunteer what those titles are and briefly why. And I've got a microphone somewhere around the room. And we need you to tell us your name if you choose to share. And so who's going to be our brave first volunteer, very quickly? Yes.
Please, and give us your name.
Thank you. I'm Alfredo Fort. I'm M&E Director for Capacity Plus project with IntraHealth. And I thought, let's start from one end of the room and then, move towards the other. Just very interesting, the 3 people I met and the responses, because we know it's a fast-moving world and everything changes over time, as well as we know that happens with governance and with turnover rates, people in ministries and such. And so 2 of the 3 people talked about adaptability. So very interesting. So moving, in fact, from regions and countries, from even continents. And so how you do that while at the same time hitting the ground running and, assuming and stepping up to your current role. So I thought that was fascinating. And the 3rd person talking about engagement. So, but that engagement was also during transition. So at least for my end, the common theme was with the move, with the change, how do you adapt fast and engage others? Thank you.
Thank you very much. Can I get another volunteer? There's a sense of caution in the room, but Anne's going to help me out.
Anne, thank you.
Well, Jody hated mine, but so I just decided to not talk to her. Mine was not as interesting as the people I spoke with, I think, but mine was entering your adolescence. And I'm referring to health, finance, and governance, which is entering its midterm. And we are about the right size, and we think we're headed in the right direction. We still have some performance issues to polish, but generally feeling adult-like. But what was more interesting to me were the people I was speaking with, and 2 of the 3 people really took the big level, and they're looking at life happiness, and so I'm feeling a little inadequate.
Okay, thank you. If you're curious about others that you didn't get a chance to talk to over lunch, you can certainly connect with them. And we'll have actually a stretch break at some stage in the morning. Let me go over the agenda, which you have in your folder. We've heard instructive comments from both Jody and Karen, and we want you to keep those in mind as we go forward. We're going to have a session that focuses on the current state of evidence, and then that will be followed by a look at the things that are already being done to generate evidence. Then we'll have lunch, and after lunch, we're going to look at the whole area of evidence gaps and look to you to give us some guidance on what the priority areas are and what the accompanying questions are. And then we'll take a look at a plan for generating some of that evidence going forward. And as Jody's indicated, the whole intention is for this to be an action-oriented session so that we leave here with a set of priorities that are endorsed and a plan of action for following through on those. So that's the basic agenda. And I've got a few suggestions for how we can be most successful. There are a lot of bright and brilliant minds in the room, so when you do share your ideas and thoughts, try to make them as pointed, as succinct as you can, both your thoughts and your questions. Listen with an open mind. Make your contributions to the group tasks that we're going to ask you to take on, and be fully present, and that requires turning off those cell phones specifically and no texting. You're going to miss some great information if you find yourself texting at the same time. Some of you have discovered on your table there are some, we call them fiddles, and they are for your use to help you remain centered. It's been proven that sometimes people take in information better when they have something in their hands to fiddle with, called kinesthetic learning. So they are there for your use throughout the day. And if you find one that you get extremely attached to, you can take it away at the end of the day. I should also note that the session is being taped this morning. And so when you do speak, it'll be important to tell us who you are. And what else am I supposed to remember here? I think that's pretty much it. But let me pause to see if there are any questions about the agenda, or Jody's already touched on the goals, but just as a friendly reminder, here are the objectives again. I don't see any hands raised for questions, so I'm going to go forward with the notion that we're on board. I do want to go back to my, where am I going here? Actions for success. I did practice a lot for a number of years, and so I want you to look at the screen. There are only 4 things there, and I need you to give me an official sign that you are committed to these, because I want to lovingly hold you accountable. And the way that you sign on to this is to turn to your left or right and give the person to the left or right a hearty handshake, and that will signify that you are on board and can be held accountable. Okay.
I'm not accountable either.
All right. So now you'll have a chance to demonstrate your active and attentive listening skills, because our first session will focus on the current state of evidence. And it's my pleasure and delight to introduce someone that I've had a chance to work with in several arenas, and that's Dr. Sarah Bennett, who is the Associate Director of the Health Systems Program and an Associate Professor at Johns Hopkins School of Public Health. So here she is. I think many of you know her. Let's give her a well-deserved applause coming up in advance of her presentation.
Thank you very much indeed, Jawara. Let me find that's the first slide, yep. So I was asked to do a couple of things, really to speak a little bit about the nature of existing evidence around governance and health, and secondly, to reflect somewhat on study design, research approaches, and what might be useful in terms of learning more about effective interventions in governance and health. And with hindsight, I wondered whether I was a little insane in agreeing to do both of those things within 40 minutes. It seems like a big task to take on. But I wanted to start on a slightly more light-hearted note. And I came across this cartoon actually by an African group recently. And it starts out by saying the tribal wisdom of the Plains Indians, passed on from generation to generation, says that when you discover that you are riding a dead horse, the best strategy is to dismount. But it continues that, however, in government, more advanced strategies are often employed, such as buying a stronger whip, changing riders, appointing a committee to study the horse, visiting other countries to see how other cultures ride dead horses, whoops, reclassifying the horse as living impaired, providing additional funding or training to improve the performance of the dead horse, and perhaps last and most important, rewriting the expected performance requirements of all horses and promoting the dead horse to a supervisory position. So besides the fact that this made me laugh, and it also reflected on the kind of strategies that governments use across the world when things aren't working out quite as they want, I thought that this also had resonance in terms of a discussion about governance, because it strikes me that many of the problems, the failures that we see in health systems across the world often have as their core root a governance problem. And instead of trying to figure out how can we really resolve that deep-rooted governance issue, I think that we often end up doing these kind of things, reclassifying this project as a success rather than a failure, hiring health workers outside of government rather than through government, creating parallel systems for drug delivery rather than really trying to ensure that there's no corruption within the existing drug system. So I think that there, besides being a little bit of fun, there was a somewhat serious note here. And it was great to see that this was a sort of being put out by a Pan-African Voices for Freedom and Justice. It was a great piece. But more seriously, what I wanted to do during this presentation was touch fairly briefly upon definitions and frameworks. That sounds very dull and a little bit boring, and I promise to keep it quick and short and to speed through that part of it. But I think it's at least worth touching on the different kind of definitions that are out there. I'm then going to try and attempt to sort of put together and provide a very high-level overview of how governance affects health and what the existing state of the evidence base about those connections look like. And I realize from the sort of opening remarks already, I was like, whoops, I haven't mentioned anything about X or about Y. But it's such a big field, governance, that it's very difficult to touch upon absolutely everything. So I've given you a sort of fairly high-level, broad overview of the existing nature of evidence. And then thirdly, I'm going to talk a little bit about framing research around governance and health, trying to think about what do we need to know and how should we go about finding out. And I was asked to talk a little bit, as I say, about sort of study designs, likely methods that might be used to further develop this field. And then I just have a couple of concluding reflection slides. So in terms of definitions and frameworks of governance, there are several definitions. The first one I've put up here is a UNDP one that you'll see really very widely referenced. It talks about the exercise of political, economic, and administrative authority in the management of a country's affairs at all levels. The second one comes from WHO, and it's actually more about stewardship. the careful and responsible management of the well-being of the population. And it comes from the World Health Report 2000, which was around health systems. And Philida Travis and colleagues did this work around stewardship and what does that mean. And I would say that this differs somewhat from governance in the sense that it's really focused more on the role of government in terms of stewarding the health sector, rather than looking more broadly at an array of different actors who I think you can say are typically involved in governance. And there's another WHO one here, this time coming from the WHO Euro Office, which I also quite like because it talks about the complex mechanisms, processes, relations and institutions through which citizens and groups articulate their interests, exercise their rights and obligations, and mediate their differences. So this is a sort of slightly different slant in terms of thinking more about multiple different actors coming together. It recognizes more fully, I think, the role of civil society and the need for mediation between these different groups as a form of governance. There's obviously a number of different governance frameworks, and I have just 2 slides here. The first one talks about governance and how it's been defined outside of the health sector. And I took the USAID's Democracy, Human Rights and Governance strategic framework and pulled from it the sort of 4 key components there. And I have to admit that I'm not sure whether this fully covers the way that USAID is talking about governance, but that talks about participation, representation, and inclusive political process and institutions. It talks about accountability of institutions and leaders to citizens and the law. And it talks about promoting and protecting universally recognized human rights, and then integrating these across the entire portfolio. And then there's 2 different definitions, one from UNDP from that same 1997 document, which talks about legitimacy and voice, direction, performance, accountability and fairness, and World Bank work by Kaufman and colleagues, which has been built up into a sort of full framework for assessing governance, which has 6 different components, where I think you'll see quite a lot of overlap with some of the dimensions in the previous categories. I won't go through all of those. So I think specific to the health sector, there has really been much less work trying to think through, well, what are the different functions involved in governing a health system? The paper that I see perhaps most widely referenced is a paper by Samin Siddiqui in the World Health Bulletin, which is it's meant to be a framework for assessing governance of a health system. It defines a fairly long list of principles that I've set out here, some of which resonate with what we've seen before about transparency, responsiveness, accountability. But it's not a very sort of succinct summary, I don't think, of what needs to happen within a governance framework. And the other paper that I've already referred to, or sort of set of papers that were connected to the World Health Report, are around domains of stewardship. And this is thinking much more about, what are the core functions that governments need to deliver on as part of governing a health system. And that talks about generation of intelligence, formulating strategic policy direction, ensuring tools for implementation, building coalitions and partnerships, ensuring a fit between policy objectives and organizational structure and culture, and ensuring accountability. I don't think that it's going to make sense for us here to try and thrash out in any kind of detailed way how we want to define this, but I do think that there is substantial amount of overlap, but also some differences between these different frameworks. And it strikes me on looking at these again, that actually there hasn't been a huge amount of work specific to the health sector in really defining what we mean around governance. One way that I like to explain some of these issues to students when I'm teaching is to think about sort of different components of a governance system. I mean, I think that when we talk about governance, we have to think not only about the sort of principles of governance, but also about the actors involved, the mechanisms that they have. So this framework sort of starts out by thinking about the actors, and recognizes that we're not just talking about government here, we're obviously talking about civil society organizations, but also market actors, private providers, industry, and that these actors exist at different levels of a health system. At the global level, which I'm not going to talk very much about today, but also at national, regional, and local levels. And often you will find that approaches to governance and policy alignment is not great between those different levels in country. And in terms of mapping out actors in a system of governance, it's also important, I think, to think about the sources of power. What power do they have to be able to influence what's going on within the system? Do they have sort of statutory power that comes from regulatory rights? Do they have financial power? What is it that allows them to hold other actors to account or to direct what's going on within the health system? This is an attempt to perhaps sort of distill some of the functions of health system governance that were in the previous slides, and I think it's worth thinking about the overall strategic direction function. How do we steer a health system? How do we sort of identify clear objectives, clear goals for that system, and build support behind them? Secondly, around system design, I think there's a lot of complicated questions that governments face about how do we balance the role of markets versus government-delivered health services. Intersectoral advocacy, what's the role for influencing what's going on across other sectors, trade, industry, education, agriculture, which I think are all extremely important in terms of achieving health outcomes. How do we promote accountability within and across the system? And how do we regulate and ensure that these objectives that we're setting out are actually, and rules that we've set, are adhered to? And I think sort of below those sort of high-level functions, you can think of a lot more smaller sort of micro mechanisms and tools that different actors can employ in order to pursue these different functions. So this slide suggests from policies, audits, regulatory statutes, community consultations, provision of information, citizen charters, and I'm sure you could name an awful lot more of mechanisms and tools that are used within the health system in order to try and deliver on the goals of health system governance. And then I know that this workshop has been framed more around how does governance affect health outcomes, the sort of final goals that we're wanting to achieve. But there are perhaps some more proximal consequences of strong and weak governance, which might be worth thinking about. Some of them are negative ones. So we see consequences such as graft and illicit payments within a health system. We might see overlapping mandates with multiple organizations all trying to do the same thing, which could also be a sign of weak governance. We might see waste. And then more positive things, the things that we would like to see: responsive health services, quality of health services, protection of poor and vulnerable populations. So that's all I was going to say in terms of an introduction, in terms of setting the scene around the definitions of governance and around different sort of frameworks of thinking about governance. I wanted to move on and talk now a little bit about how governance affects health and what do we know about this. I'm afraid there is one more framework. This is the last one, I think. Well, maybe not, but let's see. Anyway, when I was beginning to think about this, I was sort of feeling, well, you know, there are some... there's the broad governance environment which exists, which the health sector exists within. And I don't think that we can ignore that. And that will affect what goes on within the health sector within governance, which in turn affects health services and then health outcomes. But I think that we might also see very direct impacts on health outcomes. And actually, I'll talk about a few studies that have tried to look more broadly at governance, not just within the health system or the health sector, but how that affects health outcomes. Then in terms of the kind of more specific issues that we want to address, some of the broad governance issues that perhaps sort of happen outside the health sector but impact what goes on within the health sector, things like democratization, war and conflict. But I think there's also a bunch of issues that often happen outside the health sector, but bleed into what goes on within a health system. They bleed into health governance. So I'm thinking about things like corruption, decentralization, accountability. Often things like decentralization, devolution, like it's going on in Kenya at this point, are often initiated outside the health system, but have really very significant ramifications for what happens inside the health system in terms of health governance. And then I think that we also see some sort of health sector specific efforts at governance. And I'm thinking about things like patient rights charters, efforts to empower patients within the health system, initiatives around accreditation and regulation of health providers, initiatives around promoting improved intersectoral action for health. So all of these happen within the health system, but are also focused on health governance. So in terms of trying to review the evidence base, I'm going to start more on the, let's see if I can switch this on. I'm going to start more on the left-hand side around the broad governance and then sort of move over towards the right, thinking about the broad governance outside the health sector, the things that bleed into the health sector but often are initiated outside health, and then thirdly, the kind of initiatives that we see coming up from within the health sector. They all overlap a little bit, so it's not a clean and neat divide, but that's the kind of way I'm going to try and tackle this. And I should also say that in terms of looking at the evidence, this is obviously a huge body of literature and not something that I've spent the past 3 years preparing for. So I've drawn primarily upon systematic reviews and other sorts of literature reviews where they exist. Where they don't exist, I've pulled on single studies to the extent that they are available. So this is obviously not going to be 100% comprehensive, but hopefully it'll give you a feel for the nature of the literature at this point in time. So in terms of effects of broad governance factors on health services and health outcomes, that's the sort of far left of the figure that I've just presented. I think there are a number of cross-sectional studies that have explored the effect of governance measures, such as the country policy and institutional assessments that the World Bank do on health. And the kind of conclusions that these large cross-sectoral studies have typically come to, cross-sectional, sorry, is that aid and public sector spending is more effective in achieving desired outcomes in contexts of good governance, that increased health spending reduces under 5 mortality only where governance is sound, so that just increasing health sector spending alone is unlikely to have positive effects unless you have good governance. That good governance does not necessarily have, the broad good governance does not have a direct effect on health, but it has very significant indirect effects. So this paper sort of traced through how changes in those broad governance factors around democracy, around rule of law, how they affected what went on in the health sector, and found that there was often a sort of chain between good governance broadly, improved healthcare as measured by things like staff ratios, vaccine rates, and that in turn had a knock-on on health impacts, as well as having an indirect effect via income. So good governance is associated with higher incomes, which in turn affects health outcomes. And public health spending lowers child mortality rates more in countries with good governance. So there's a bunch of studies here, all at a very high level. Some have focused more specifically on democratization. The first of these is also a large cross-sectional study of different countries that found substantial evidence that democratization was associated with higher levels of public health, including better infant mortality, life expectancy, and immunization coverage. I think that there has been much less study of what happens within the health sector as a consequence of democratization. But there was one recent paper by Karen Greppin and colleague that looked at the effects of democratization on the development of universal health coverage, and was actually comparing Senegal, Ghana, and Kenya, and arguing that one of the reasons why Ghana had been able to move forward with UHC was because of a very competitive electoral system. The second, if you remember, of the sort of blocks in the broad governance factors that I was looking at was around war, conflict, and health. And obviously, conflict is related to death and injury and is a major contributor to the global burden of disease. Chris Murray documented this very early on, well, not very early on, about 10 years ago in the British Medical Journal. There's been much less study of the indirect effects of conflict on public health. But the studies that do exist suggest that the indirect effects, i.e. not the direct injuries during war and conflict, but what happens afterwards in terms of the sort of negative consequence, the longer lasting negative consequences on health systems, was perhaps twice the impact of the direct effects. So they, in this paper by Gobara et al., in particular highlighted the raised incidence of infectious diseases as things like vaccine rates dropped during periods of war and conflict, and sort of health systems decayed during that period. I think that there has been a very substantial focus within the health sector on how do we rebuild health systems after a conflict has occurred. But it's not necessarily, there's more sort of anecdotal case studies, I think, than sort of larger and more rigorous studies. So moving on to those sort of factors around governance that bleed a little into what goes, or bleed a lot into in what goes on within the health sector. I wanted to start out just touching upon the issues of corruption and weak financial management. Taryn Vian wrote a very nice paper that I'll refer to again that talks about corruption as the abuse of entrusted power for private gain. And we know that corruption is a very widespread problem in the health sector, both in low and middle income countries and in high income countries as well. Various data to support that. You know, the counterfeit drug market, you'll see different figures, but one recent one was that it's worth $75 billion a year. Public expenditure tracking surveys. These same surveys are very widely cited that were done in Uganda and Ghana about 10 years, more than 10 years ago now, say that 70–80% of non-salary recurrent expenditures were leaking out of the health system. And also often widespread informal payments to healthcare workers. In Cambodia, income from informal payments was assessed to be 5 times that from regular government salaries, and in Bangladesh about 10 times that from regular government salaries. So a lot of different ways in which corruption in different shapes and forms affects what goes on in the health sector. And also just to point out that I don't think it's just about leakage, it's about how it distorts the way in which the health system works and creates huge inefficiencies for the system as a whole. Just to add to that some charts. These come from a paper that Maureen Lewis wrote while she was at the Center for Global Development. This is around perception of corruption in the health sector. You can see in Pakistan that about 95% of the population perceived the health sector to be corrupt, and surprisingly high in places like Sri Lanka as well. Absenteeism rates among health workers, again, some extremely high absenteeism rates. I was surprised by the Dominican Republic here having such high rates around hospital doctors. The Vian paper also provides an extremely nice sort of conceptual framework for thinking about how different factors are likely to affect corruption. And she talks about, how easy is it to rationalize being corrupt within the health sector? What are the opportunities for abuse? And what are the pressures to abuse? Things like low salaries, pressures from clients. My sense is, and I'll talk more about this, that we've done some work around some of these opportunities to abuse, around accountability, citizen voice. We've done very little around how people rationalize abuse within the health sector. So I think we've barely touched upon understanding the different connections that Vian points out here. Moving along, and I'm sorry this is such a Cook's tour of so many different issues within governance. The next one is around decentralization. This was a hugely debated topic, I would say, 15, 20 years ago. It seems to be one of those issues that sort of fades in and fades out a little bit. The evidence, such as it is, suggests that financial decentralization can have some very positive effects on health. One study, which was a large cross-country study that looked at the extent of financial decentralization, found strong associations with lower infant mortality rates. But then when you start looking at the nuances of what's gone on in individual countries throughout the decentralization process, I think the picture becomes a lot more mixed. So from Tanzania and Uganda, we seem to have some positive effects, particularly around higher service utilization after decentralization. But then in Zambia, we saw more negative effects. And I think this kind of phenomenon of having very mixed findings around governance interventions is quite common. And it's often because the intervention is not a single unified intervention. It's not like one bullet that looks the same in every country. So I think that perhaps some of the more interesting work in this field has really been trying to unpack, well, what is decentralization? How does it look? What does it look like in different contexts? And Tom Bossert, for example, did some very interesting work in that a while ago. Wanted to move on and talk a little bit about accountability, patient rights, and empowerment. And my sense is that this is a hot field at this point in time. I was recently at a meeting that included a bunch of academic political scientists, and I was really surprised at the extent to which their core focus was really around accountability, randomized control trials of different accountability measures. But I think that perhaps some of this was triggered by the World Bank report 2003 on service delivery, which set out this very simple but widely used figure that sort of contrasts different ways of holding providers accountable and distinguishes between the short route, the sort of direct communities or patients engaging with providers versus the long route of accountability where, you know, we have to vote in new politicians who pass down new messages or new compacts with providers. So I wanted to start with the short route of accountability, community accountability first. Obviously, there's multiple mechanisms here that have been used and that people are experimenting with in different contexts, from information dissemination. I think a very well-known one being the District Health Barometer in South Africa, where they give, you know, sort of red-green traffic light figures on every district in South Africa and make it publicly available, which sort of stimulates quite a lot of discussion. To village health committees, community health committees, approaches to community monitoring, and often these are supplemented by informational technologies, so getting people to, you know, report on health worker absenteeism or things like that. There have been a few randomized control trials that have demonstrated that these kind of interventions can have really significant effects. And this Bjorkman and Svensson paper that I cite here has been very widely cited in the literature and demonstrated a 35% reduction in child mortality over quite a short time period, combining sort of community monitoring, data provision, and discussion in Uganda. However, once you start to look more broadly at the literature in this space and what's happened outside of randomized control trials, I think that the picture begins to look quite different. So Sassi Molyneux did a fairly recent review that tried to identify in low and middle income countries all of the different approaches that had tried to strengthen community accountability. They found 19 studies that looked at village health committees, and they've thought that 4 of those demonstrated sort of largely positive findings about the effects of village health committees, but the rest of them were much more mixed in terms of what they concluded. And they sort of said that there are some real challenges in terms of being able to make these kind of interventions work effectively. Frequently, community structures are not inclusive. So, you know, I'm sure I'm not, these are familiar stories, but they're worth remembering that when we set up village health committees, is it the women, is it the most vulnerable, the poorest in the community who have voice and are included in those? And to what extent are these mechanisms sustainable and institutionalized? You know, there's a feeling that sometimes they're there on paper, but they're not really operating in practice. David McCoy did a rather similar review, and he talked a lot about the difficulties of transferring lessons between different countries and different studies, given how diverse these different mechanisms are, the extent to which, you know, the community meetings have been really facilitated by skilled facilitators versus just villagers being told to set these things up. Molyneux also searched for studies around public report cards, patient rights charters, and found 1 study on each from low and middle income countries, so a very limited evidence base there. I'm going to talk very briefly about sort of upward accountability, i.e. measures to try and make healthcare providers more accountable to managers or policymakers within the health system. I do think that there's much more substantive evidence around some of these upward accountability measures. So, for example, performance-based financing, there are actually 4 systematic reviews that have looked at performance-based financing scheme. They all have sort of slightly nuanced findings in terms of how effective PBF is. And again, the sort of message seems to be there is a lot of promise to these schemes, but the devil is in the detail. You really need to get the design right. There are a couple of systematic reviews that have looked at contracting for health services in low and middle income countries. They conclude that contracting can increase access and utilization of services, but the evidence around improvements in quality is unclear. And it seems to me that actually it's about the improvements in quality that really links to the notions of accountability and governance. I mean, contracting out is a potential mechanism to more clearly specify the quantity and quality of services that providers are meant to deliver, and the evidence on that seems to be weak. Balanced scorecards, no systematic reviews. Colleagues of mine talk a lot about a study they were involved in Afghanistan that was providing balanced scorecard indicators to the government on an annual basis. And that seems to have led to quite a lot of quality improvements. But I think that they would also caveat that by saying there were other factors in the environment that supported that implementation. Regulation and accreditation. I'm nearing the end of this long list of evidence at this point. Regulation and accreditation. I think regulation is often thought to be a critical element of what should occur in terms of governance in the health sector, but it's widely thought to be ineffectual. I've quoted an older study and a newer study here, both making the same point. And I think that there's really very limited evidence about strategies to strengthen regulation or regulatory capacity. This is something I've been tracking. My very early work was around private healthcare providers, health markets, and I've always thought we need to do more about regulation, but I think people have found it very difficult to get traction on this particular question. And similarly, accreditation, there was a recent review by Totten and colleagues which looked at accreditation. It found 198 studies on accreditation, one of which was in a low and middle income country. So obviously a limited evidence base there. Finally, this wasn't really sort of one of the interventions that I had put up, but I wanted to conclude this section by just saying I think there's a number of other sort of bread and butter business that government has to do, whether it's talking about designing mixed health systems, trying to figure out how to get public and private providers to work together, whether it's reaching out to other sectors. And I think it's widely acknowledged that government requires capacity for these kind of core functions. Often these functions imply quite new skills and capacities for government. They involve things like partnership building, system thinking, strategic planning, conflict resolution, not skills that have been, the traditional domains of government. But there's very limited evidence, I think, on how to effectively build such capacities within ministries of health. So the next sort of segment steps back and sort of says, well, there's all these big needs for evidence out there. How do we figure out, what should be priorities? And once we've got that clear, what kind of research, study designs, and methods should we be thinking about? So I've sort of said this already. I think that governance is a topic where we all acknowledge it to be important, but there's very limited evidence base for much of what we do, I think, in this field. I think obviously in terms of moving forward, we need to think about what will have maximum impact on USAID programming. We should also check out what other actors are investing in, and I know that there's a panel later today which will talk a little bit more about this. I threw in a couple of initiatives that I was aware of here. IDRC has had a long-standing, it used to be called Governance, Equity and Health, is now Governance for Equity and Health Systems initiative, which is only for low and middle income researchers. It's a little bit scattered in my view. It does very good work at the country level, doesn't necessarily sort of add up to a bigger picture. And IIIE, together with DFID and one other partner, I think, did a call for randomized control trials on transparency and accountability about 18 months ago, and there's work going on there. But I think we also need to ask, what is feasible, what research is doable and likely to deliver really practical guidance? And sort of building on that, I think it's clear that the research questions we arrive at should drive the kind of study designs and research methods we choose to use. So I've divided my comments on research design into three parts according to the type of question that you might be asking. So the first concerns questions regarding the effects of intervention. What effect does this governance intervention have on outcomes? The second is more descriptive or exploratory questions, and the third is explanatory, and I think that the next slides will illustrate that. So in terms of questions regarding influence or effects, these are the kind of questions which ask, does X reform influence service outcomes or coverage, where X is a governance thing? Does village health committees influence service outcomes or coverage? Does improved regulation of the private sector influence service outcomes or coverage? And this is the area where you typically expect to see sort of randomized control trials, before and after studies, time series analysis, which can deliver really high quality evidence on impact. But often these kind of studies don't explain how and why those impacts occur. What were the mechanisms through which those impacts permeated? The other kind of studies that I would include here are these sort of larger cross-sectional studies that I talked about how broad issues, measures of democracy or governance affect health outcomes. And again, these are good at explaining associations or identifying associations, identifying how strong they are, but don't typically explain the mechanisms through which the impacts occurred. A second sort of group of study designs would be around more descriptive and exploratory questions. For example, how do health workers perceive corruption? Do they see it as a barrier to their work? Do they feel comfortable about it, uncomfortable about it? So there's been there was an interesting study by Stringini, which looked at provider attitudes to informal payments in Tanzania, and providers were really uncomfortable with informal payments, which obviously provides you with an entry route to thinking about how do you improve and strengthen, how do you address informal payments. Other sort of questions might be, to what extent is community decision-making about health really inclusive? Participatory action research might be a way to take that. How does Ministry of Health structure support or undermine, how does MOH structure support or undermine health in all policies? And you could think about case studies of different countries and how they have organized their work here. So typically, answering these kind of more descriptive and exploratory questions, you would use more qualitative research approaches. I've given you sort of suggested designs here. These kind of approaches are very good at explaining complex social phenomena. They are less good in terms of, they're not good at measuring impact. How big is the impact of a particular intervention? The third and final category I wanted to talk about were sort of explanatory questions, such as, under what circumstances are community accountability mechanisms effective? So, going back to what I was saying about accountability and village health committees, we know that they can be effective, but what are the conditions that actually make them so? And I would argue that these kind of impact evaluations, pure impact evaluations, are unlikely to get at these causal mechanisms, and we need to use more mixed methods. We need to bring together the sort of impact evaluation design with more qualitative research that can cast light on the mechanisms through which an intervention is working. And I think the other area, the other sort of type of study design that might be productive in this field is around sort of implementation research. And so David Peter and colleagues have recently written about regulatory interventions, and maybe what we should be doing there is more implementation research. So we try things out, we study them, we adapt the design of the regulation, and we keep going like that. So I hope that that has given you at least some overview of the different options that we have in terms of how we collect, analyze data to answer the different research questions. I think that the most important thing really is that we fix on the research questions and then let that drive the kind of study design that we're using. I just wanted to finish with a couple of final reflections. I'm repeating myself, but I think it bears repeating. Governance in health is a wide and largely untouched canvas. So it's great to see some initiative to try and seize that bull by the horns and push it forward here. But I think we should also recognize that it's untouched due to multiple challenges. I think this question of lack of conceptual clarity, differing definitions and frameworks is a little bit of an issue. I don't think we should try and sort of flog it too much, that dead horse again, but I do think that it's worth bearing that in mind. I think there's also political sensitivities around doing this kind of work. Corruption is the most obvious one, but each time we talk about government capacity, I think that that can also be challenging. And I think it's widely recognized as a difficult area for effective research and action. On a completely separate piece of work, we've been doing some interviews with mission staff recently, and they often say something like, governance is really important, but boy, that one's difficult. So it leads me to think that we need to focus, we need to demonstrate early wins in whatever we take on, and that we need to make sure that the studies or the evidence that we gather assists implementation and aids the impact of programs. Lastly, and I hope that I've been able to express this throughout the presentation, I think that governance is an inherently complex phenomenon. Going back to those 6 building blocks that Jody put up earlier, all of them are pretty tricky. You know, service delivery requires coordinating health workers and drugs and all the rest of it. But governance works at so many different levels, and I think is probably inherently more complex than any of the other building blocks. And I'm not sure if this is the right community for this message, but I see from where I sit an increasing emphasis, both amongst sort of the public health community and the development of the community at this point in time, on sort of scientific rigor, the gold standard being randomized control trials so that we really know the effects of these things. And I think that given the complexity and governance, those are not necessarily the obvious route to be going. I think that they may they often underplay the need to understand why or how effects occur, and I think that's really important in this field. Not just knowing, oh, this can be effective, but when will it be effective? Why will it be effective? How can we really make this intervention effective? Secondly, it worries me that some of these very widely publicized randomized control trials focus on very discrete interventions in the health system rather than looking at the whole of the governance system and how it all fits together, and thus neglect questions of scale-up and feasibility, which I think we're all really concerned about. There's no point in doing something successfully in 6 villages. We need to be able to do it successfully at the level of nations and states. And finally, just to say that I think sometimes the perception of impact evaluations and randomized control trials as being the sort of gold standard for rigor is sometimes a little misplaced. Qualitative research, other approaches also have rigor. It's just expressed and measured in different ways. So I will close there, and I hope that that's given you at least some food for thought going forward.
So we'd like for you to take some time, and let me see, how do I work this? And at your tables, I'm going to give you another 10 minutes or so to think back on the instructive presentation that Sarah has just offered. And her presentation may have triggered some questions for you, so chat at your table about those possibilities. In addition, you may have some comments that you'd like to offer to supplement the ideas that Sarah has presented. So it's a time for you to chat for about 10 minutes and settle on 2 either questions or comments that you'd like to offer from your table. And then we'll start entertaining either the comments or the questions. And both are equally valuable because we respect the fact that there's a lot of knowledge in the room. And so there may be some things that, as you were listening to Sarah, you said, aha, I'd like to add this to the thoughts that she's presented, or I'm still puzzled a bit about one thing that she said, and I'd like to surface that as a question. And in the end, we're not just looking to Sarah to answer the questions, because there may be some answers in the room. So this is a community venture. So you'll be posing the questions, they'll be heard, or comments, and we will collectively either respond to them or offer comments on the comments, so to get you actively engaged in the process. The next 10 minutes is yours, and then we'll hear from you. And have a spokesperson prepared to offer your questions or comments. No, you're fine. Now I've got to figure out. Did they put? Well, did they put your slides? I guess they did. Yep. Mm-hmm. Yep. Yep. That's you. Right. So then, if we come over here, thank you, and there we go. Great. Good job. She wants the slides.
Johns Hopkins?
Yes. Yeah.
You're amazing. Thanks. Really captivating.
Where are you based?
I'm here. My name is Cynthia International. I'm outside.
Why is it not recognizing those words? Let me give it.
Another port.
That one, yeah. And you want it anywhere in particular?
Yeah.
Just say think it's done. It's so flashy, I don't know.
If you open it, does it exist? Can you see it?
That one there, just find it.
Okay, great. Thank you so much.
Pleasure.
I don't want to ask you for like. I know there's a question now for that, but I'm not sure if I should ask this question. It's like when you put the diagram of the 6 building blocks. Has anybody ever mentioned what to start with?
No.
You know, when you want to, do governance, what to start with?
Yeah, no, I think it's a good challenge for us.
Has there been studies about this? Like which of the building blocks you should start with?
I think there's some policy studies. Lucy Johnson quite a long while ago looked at big health financing reforms. We often like health financing reforms are going to involve reforms around service delivery, reforms around governance issues. So they talked a little bit about sequencing issues, but I haven't seen good research sequencing majors.
Okay. All right. Thank you. Thank you, sir.
Basically because that started in 2004 and governance was
Take another few minutes, please.
beginning. So you've got trying to use out this. Principles. Instead of doing things from scratch, possibly to do something and looking at it and looking at the options.
So it seems like the message from all of us was that it's more about how research can help you, especially with the USAID perspective of practical how to effectively influence various possibilities that the USAID missions and projects pharmaceutical health systems know what to do, which means how with the how. That there's a place for the randomized control trials to say, once you apply those,
I'm eavesdropping on some of these other conversations. Just trying to figure out what where they go.
Places like that.
necessary but insufficient, is that what's really missing more on the how, what can we do to influence
It is sort of like, there is something sort of sometimes bureaucracy to make things, I mean, the Poland Bureau said, we want methadone one day, and the next day, 500 methadone. So, but I think there's a danger